So this talk will be by Modibo Camara, and the title for the talk is Treatment Approval.
Okay. Hi, everyone. There we go. So many of you may be familiar with the problem of treatment choice, or maybe you know it by a different name. It's a problem of a doctor that uses clinical trial data to assign treatments to patients. So maybe you know it under the name of classification or statistical learning or statistical decision making, what have you. In econometrics, we call it treatment choice. This is basically a statistical problem, and it's fairly well understood from a variety of different perspectives. What I want to consider is sort of a problem that's one level up, the problem of treatment approval. And here we think about a regulator that uses clinical trial data to restrict the treatments that a doctor can assign. Now, this is a delegation problem, but it's going to raise interesting new statistical challenges. Okay, so where I want to start is by looking at treatment approval policy as currently done in the United States to see how maybe I and other people in this community can evaluate and improve. So the basic standard for approving treatments within the United States by law is that you need to have substantial evidence that the treatment is effective. Now, this is a quote from a draft guidance from the FDA for industry, but basically what it says is that substantial evidence of effectiveness means what you think it means, a high level of statistical confidence. Right? So even if a treatment is only just a little bit effective, but you're very confident, then you might approve it. But if you think that a treatment might be very effective, but you're not very confident, then you might not approve it. Now, this is difficult to justify from the perspective of treatment choice, and there's been a lot of work written criticizing the use of hypothesis testing for decision making. As I show in the paper, it's also difficult to justify from a standard delegation standpoint if you don't explicitly consider the learning problem of the doctor. So the framework that I use is that of a regulator approving treatments that a doctor can prescribe. And the regulator and the doctor are similar in some dimensions and different in others. They're similar in the sense that they both observe the clinical trial data, right? And by law, these clinical trials have to be made public. So they can both learn about the effectiveness of a treatment. The regulator and the doctor will differ in the sense that the doctor has more information about the treatment costs than the regulator. So treatment costs could be things like, patient preferences, right? Maybe inconvenience for the patient, the price of the drug at the time of prescription, or things like the doctor's capacity to deliver a certain treatment effectively. And finally, I'm going to assume that both the regulator and the doctor are benevolent. They both care about the patient welfare. So my goal here is to design a statistical decision rule for the regulator under reasonable assumptions about the doctor's behavior. Okay? And what I mean by reasonable is going to be this concept of statistical tractability that I introduced in the work. So the main results that I have, so the result is that the optimal approval rule in my model resembles stepwise multiple hypothesis testing in the sense that it resembles stepwise multiple hypothesis testing, which means that it actually very closely resembles the actual treatment approval policy used by the FDA. By that I mean that the treatment is approved if and only if the sample treatment effect exceeds some critical value, and that critical value is increasing as more treatments are approved. Now, why is this? Well, basically, it comes from a learning theoretic perspective that if we approve too many drugs, we are making the doctor's learning problem more complex. Right? So the reason to only approve a subset of the available drugs is because we want to make sure that the doctor's learning problem is relatively simple to avoid the possibility that the doctor makes large mistakes. In the paper, I extend this framework and the results to a more abstract problem of mechanism design with a common data set. That's the actual title of the paper, where we have a designer and a single agent. Both of them are learning from a data set. In other words, we're replacing standard common prior assumptions or common knowledge assumptions with learning from a common data set. And one of the things we see in the treatment approval example and others in the paper is that this learning theoretic model of mechanism design can provide micro foundations for simple policies. Okay, thank you very much.